A couple of the things that I wanted to talk about today are really just to introduce some of the conversation for what I had hoped to be really kind of a workshop and understand what questions you all have now that we're outside of the federal public health emergency and see what questions I can help answer. I'm sure there are a lot. There's still a lot of unknowns, but there are quite a few things that we do know at this point now that we have the final date and the final date has ended. I did want to mention the technical assistance through HTRC. We had a session, gosh, it's been a month or so ago now, Molly, where we emphasized the HTRC as a resource. And as Molly mentioned, we were getting a lot of questions, which I love. I love the detailed, specific questions that are coming in through that line that we can help research and give you the citation, the Medicare document, the Medicaid reference for you that can help guide how you operationalize telehealth in your practices. So first and foremost, I think this is our first or one of our first sessions after the federal public health emergency has officially ended. So May 11th, 2023 was the last day of the federal public health emergency that under the Department of Health and Human Services. So I wanted to go through just a couple of things and what the immediate impact of the end of the PHE is. As of February 12th, there are a couple of important deadlines with respect to telehealth services for us to keep in mind. The day that the public health emergency ended, certain telehealth flexibilities went away. We also have some telehealth flexibilities that will be extended at least 151 days after May 12th, 2023. In just a few weeks, I expect early to mid-July, we will also see the Medicare proposed physician fee schedule that outlines policy Medicare plans to implement for 2024, January 1st, 2024. It's hard to fathom that it's been 4 years since the PHE started. What I anticipate we might see in that policy are some of the flexibilities that are currently at 151 days get extended to either the end of the calendar year, but most likely we'll have several flexibilities that will be extended through December 31st of 2024. And the reason I say I anticipate that, there are certain flexibilities Medicare has to extend to December 31st, 2024, based on a piece of legislation at the end of 2022, mandating those extensions. Initially, early last year, we had certain extensions that the legislature said must extend for 151 days after the PHE. And that's what we saw in Medicare's rulemaking last year. They mirrored what the legislature mandated they do. Because of the new piece of legislation in December, at the federal level, we've not yet had the rulemaking process under the Medicare physician fee schedule. So I anticipate this year's proposed rule will do the same thing that we saw last year and propose and ultimately extend many of those flexibilities that currently would expire in October through December 31st of 2024. We'll keep you posted, of course, once the proposed rule comes out. I anticipate telehealth will be a big topic in that proposed rule, and HTRC will help consolidate the several thousand pages for you so you know what's in there with respect to telehealth. But I want to focus right now on the immediate impact of May 12th, 2023, and what impact that date has on various telehealth flexibilities that we had during the public health emergency. Really, we revert back to pre-PHE rules when it comes to Medicare, where we find some of the most restrictive telehealth rules. And so I want to go through some of those that reverted back to pre-PHE policy, and then we can talk about what's here to stay and then what might have different end dates depending on the flexibility. So May 12th, 2023, first day of the post-COVID PHE era, the frequency of subsequent hospital visits, which can still be rendered via telehealth, but now the frequency is limited to once every 3 days. That was always the case prior to the public health emergency. The flexibility that we saw during the PHE is that there was no frequency limit. Providers could, if they wanted or needed to, see a patient and bill subsequent hospital visits every single day of an inpatient stay via telehealth if they wanted to. Effective May 12, 2023, critical access hospitals are no longer eligible distant site providers, distant site billers for telehealth services. They always have been eligible originating sites to bill an originating site fee for telehealth, meaning that's where the patient is located in the critical access hospital. If another eligible distant site provider saw a patient via telehealth within the CAH. The flexibility during the PHE that we had also allowed them to be the distant site providers, really for patients who were at home, or maybe you participated in the Hospital Without Walls program or Hospital in Your Home programs. That enabled critical access hospitals to provide telehealth and bill as the CAH as the distance site telehealth provider. That flexibility for critical access hospitals has gone away. For skilled nursing facilities, the skilled nursing facility subsequent visits, just like hospital visits, have been on the Medicare telehealth list even before the COVID public health emergency. Prior to the COVID PHE, telehealth visits to patients in a skilled nursing facility was limited to once every 30 days. During the PHE, that frequency limit went away. Now, May 12th and after, that frequency limit has been modified slightly and made more flexible than what we had before, but a frequency limit still exists, and telehealth can only be provided by a provider or providers of the same specialty in the same group practice to a patient in a skilled nursing facility via telehealth once every 14 days. So now I'll step back from those provider-specific changes, and let me talk just briefly, and I didn't put it on the slide here, but I want to talk about some of the things that have not changed. Effective May 12th, one of the things that has not changed, a flexibility that is continuing for a period of time to be determined, is the eligible originating site where the patient is located still includes the patient's home. And that was not an eligible originating site, with very, very, very limited exceptions prior to the COVID PHE. So that has not changed. What has not changed yet currently is set to expire 151 days after the PHE ends, but through legislation at the end of 2022 that I expect Medicare will adopt as policy, we'll know more about that in a couple of weeks, is that speech therapists, physical therapists, and occupational therapists continue to be eligible distant site telehealth providers for Medicare for at least 151 days after the public health emergency ended. And again, I expect that to be extended because the legislation mandated that option continue through December 31st of 2024. So those are some important things that have not changed as of May 12th. Some other questions that came up in last year's the physician fee schedule and some of the telehealth PHE discussions and guidance that CMS has put out in the last few months. The question of the modality, audio-visual interactive telecommunications technology versus audio only, and what's allowed as of May 12th and after. One of the things that generally has not changed yet is that we can still deliver telehealth to a patient with Medicare via audio-only technology. The duration of that will depend on some policy changes that we expect to see in a few weeks, but at least 151 days. I expect it to be extended through December 31st of 2024. But one thing that did change to be mindful of during the PHE, if a service you provided was addressed, coverage for that service by Medicare is addressed through a national coverage determination policy or local coverage determination policy. And within those policies, there is a requirement for an in-person visit. The flexibility to meet that requirement via telehealth that we had during the public health emergency has gone away. So when coverage requirements mandate an in-person visit, the ability to use telehealth is no longer available as of May 12th. Now, there are several services that I kind of loosely refer to these as quasi-telehealth because I think from a layman's term, we think of them as telehealth, but they don't technically fall under Medicare's telehealth rules. So for some of these, the care management, remote monitoring, and virtual services that I'm talking about, these are generally not live interactive services. They're done kind of behind the scenes outside of an in-person or face-to-face visit. But because they are not classified as telehealth under Medicare rules, we're not restricted to eligible originating sites, rural geographic areas, eligible distant site providers, and a lot of those restrictions. So care management services, things like chronic care management, behavioral health integration, psychiatric collaborative care. There is a care management benefit category under the Social Security Act, and those services that fall under the care management group can only be rendered to established patients effective May 12th. During the PHE, we had a flexibility that would allow us to also provide those services to new patients. Prior to the PHE, they were established patient-only services. And the reason for that, to initiate care management, one of the requirements is that you have a comprehensive initial visit where care management is discussed. You get the patient's consent. The patient understands that there will be cost sharing for these services that happen kind of behind the scenes, non-face-to-face. So now that requirement has been renewed that they're only eligible for established patients. Remote patient monitoring, or probably more precisely, remote physiologic monitoring. The RPM services that you find within the evaluation and management section of your code book, those are now, again, for established patients only. During the public health emergency, we had the flexibility to provide remote patient monitoring to new patients. And the thought or the rationale is we may have patients discharging from the hospital needing respiratory monitoring. And as they transition from acute care back to ambulatory, they may be new to the provider who could monitor them remotely without having in-person potential exposure or infection risks with healthcare providers to monitor their COVID recovery. One of the flexibilities then specific to COVID for remote patient monitoring during the PHE was the requirement that you see in the code book for RPM codes that monitoring has to happen for at least 16 days out of the calendar month or the 30-day period, depending on which code you're looking at, was waived when the monitoring was for COVID recovery, where as long as you had 2 days of monitoring for COVID, you could still report a monthly RPM code. That has also gone away effective May 12th, and you need a minimum of 16 days of monitoring, which is the time frame that you'll find in the code book for those services. And the same thing for virtual services, virtual check-ins where a patient can exchange a photograph or a video, and the provider can determine the need for an evaluation and management service that does not lead to an E&M within the next 7 days or next available appointment. are limited to established patients only, as are e-visits, which I think of as like portal message communications. They are asynchronous communications about well-defined minor acute conditions. A question that a lot of you have asked in the last 6 months, maybe one of the most popular questions, was what happens to the flexibility that we had during the public health emergency under the Ryan-Haidt Act. And the Ryan-Haidt Act dictates how controlled substances and whether controlled substances can be prescribed during the course of a telehealth visit. So I want to kind of work my way from the most recent development to some things that have happened in the last few months. The most important thing that you need to know, on May 10th, the Drug Enforcement Administration announced that they would temporarily extend all of the flexibilities that we had during COVID for the prescription and renewal of prescriptions in the course of a telehealth visit through November 11th of 2023. The reason for that extension is that back in February, that was around the time that we had a final announcement on the date that the public health emergency was definitively going to end. The DEA published a proposed rule for some concepts that they wanted to continue with respect to prescriptions of controlled substances when the PHE ends. That didn't give the DEA a lot of time, nor the public a lot of time to read those rules, to provide comment, and then for the DEA to issue a final rule. In fact, that is the reason for the May 10th extension, because the DEA said they received more than 18,000 comments to that proposed rule, and they really wanted to take the time to read them and be mindful of what those comments were before they issued a proposed rule. In the proposed rule, though, I think this is instructive of what we might see come from the Drug Enforcement Administration. So November 12th, some controlled substance prescription policies that you may want to keep in the back of your mind in the event your providers are prescribing during telehealth visits. There's two new limited options for telemedicine prescribing of controlled substances without a prior in-person exam. And that piece of the Ryan-Haidt Act, that piece of the flexibilities that we had during the COVID emergency is probably the biggest question that I've received from you all and others throughout Kansas, Missouri, and Oklahoma about what happens post-PHE, whether that in-person exam prior to prescribing controlled substances during a telehealth visit will again be required. And I won't say there will be. There is a proposal that it will be an option, but it's not what we had during the public health emergency. It's not wide open. It would be more limited if the DEA's proposal is finalized. They would discontinue the ability to prescribe during a telehealth visit controlled substance if the patient has not had an in-person exam, with those limited exceptions. One of those exceptions, when there's an initial prescription with no more than 30 days, so it's kind of to meet an immediate need, but renewing that prescription would not be possible without the in-person exam. And there are, again, a couple more exceptions to that, but know that they are much more limited than what we had during the public health emergency and what we will have through November 11th. If the patient were to require a Schedule 2, 3, 4, or 5 narcotic medication with a very narrow exception for opioid use disorder, an in-person exam would be required before any prescription could be issued during the telehealth visit for those medications. So those are some important changes to keep in mind. I believe the comment period for February, March, April, the comment period has expired. You can view public comments online to that proposed rule. Right now, the DEA is taking those public comments under advisement to prepare their final policy. And then quickly, a couple of just brief kind of enrollment and billing changes to be aware of. As of May 12th, If your providers are routinely providing services from another location than their typical practice address, let's say every Monday, Dr. Marting has a work from home day and provides telehealth services. Now, after the public health emergency ended, that home needs to be enrolled with Medicare as a practice location. There are some implications to that. Providers' practice locations where they render services from can be publicly available. So providers who are routinely doing that, who meet the criteria for a location that needs to be reported, you'll want to take a look at that. You'll want to make sure you get the enrollment and that the proper service location is translated on the claim when the provider is rendering telehealth services from that alternate practice location. And then one quick commercial payer policy update. Blue Cross and Blue Shield of Kansas City's telehealth policy announced that effective May 12th, they want providers to revert to using the place of service codes 02 for telehealth service rendered to a patient whose location is not at home, or place of service 10, a telehealth service rendered to a patient who is at home on the claim, rather than using the place of service code that would describe the location that would have been used had that service been delivered in person, like 11, the office, or 22 for hospital services and so on.